Hi, my name is Meryl Cohen. I am from the Children's Hospital of Philadelphia, and I'm going to be speaking to you about pediatric left ventricular noncompaction. I have nothing to disclose. The learning objectives for today are to define and identify the potential causes of left ventricular noncompaction, to explain the different imaging modalities that we use to make this diagnosis, and to recognize the clinical outcomes for children who have the diagnosis of left ventricular noncompaction. Left ventricular noncompaction has a fairly broad diagnosis and definition. There is a typically spongy myocardium with trabeculations. There is a thin compacted layer of the myocardium that is seen. There are classically deep intertrabecular recesses that are communicating with the left ventricular cavity that we can see by color Doppler on echocardiography. And if you're looking at a pathologic specimen, the endocardium can be identified on these trabeculations. Of note, even though we're talking about left ventricular noncompaction, you can see noncompaction of the right ventricle as well. There are synonyms for this diagnosis, although more classically in the last decade, most people have gone to the term noncompaction. And the synonyms include spongy myocardium, hypertrabeculated myocardium, and persistent embryonic myocardium. Prevalence of LV noncompaction in the adult population is about 0.1%. However, we know that this diagnosis may be have a higher prevalence because we may miss the diagnosis, and more importantly, we don't know the denominator, as there may be many patients out there who don't have an echocardiogram and go unrecognized. Within the spectrum of children, it's the third most common cardiomyopathy. The American Heart Association defines it as a genetic cardiomyopathy, and the European Society of Cardiology defines it as unclassified. The presentation is quite variable, anywhere from early infancy to childhood, adolescence, and of course adulthood. And with regard to the pediatric population, LV noncompaction can occur in isolation, or it can be seen in association with congenital heart disease. The adult and pediatric presentation of LV noncompaction is quite variable. In the adult population, patients with LV noncompaction typically present with signs and symptoms of heart failure. They can have arrhythmias. They can have thromboembolic events and stroke or sudden cardiac death. But in children, the presentation is much more variable. Some children with LV noncompaction present with failure to thrive, feeding intolerance, or respiratory symptoms. We typically see an earlier presentation of LV noncompaction when it is seen in association with congenital heart disease. And this is a table from a paper from the group at Texas Children's Hospital from 2003, which shows you the clinical presentation of LV noncompaction in 36 children. And you can see that there's a spectrum of presentation, including syncope and murmur. Some of the patients were asymptomatic, some just had abnormal tests, and such that half of the patients have a benign presentation in childhood. What is the etiology of LV noncompaction? It is genetically heterogeneous, so there can be sporadic cases as well as cases that run in families. There are particular genes that have been implicated in its diagnosis, most classically the TAS gene, which is associated with Barth syndrome, but also other genes that are listed here, including genes that are associated with the proteins that make up the myocardial cells. And it can be seen in association with syndromes as well, most classically trisomy 13. This is an example of a human embryo at Carnegie stage 16. So what you can see here is that here's the left ventricle and the right ventricle. And you can see that we all start off life with noncompaction of both ventricles. The black lines here represent the trabeculated portion of the myocardium. And over time, during the development of the embryo, these areas become more compacted. And in normal development, we don't exactly understand how this happens, but either the compacted layer expands or the non-compacted layer regresses as the embryo and fetus develops. This is a path specimen. On the left, an A panel is a normal heart. On B is a patient with non-compaction. And I direct your attention to this paper by Pediatric and colleagues in JACE in 2012, which is an excellent review of LV non-compaction. And what you can see from these specimens is a significantly compacted layer on the left and multiple trabeculations of both the left and right ventricle on the right in the B panel. And you can see this at the microscopic level in the C panel as well. What about non-compaction in association with congenital heart disease? There's a spectrum of diseases that you can see that have non-compaction. Most specifically, you can see it in association with muscular ventricular septal defects, so-called Swiss cheese ventricular septum. You can see it in patients who have left or right ventricular outflow tract obstruction, such as those with hypoplastic left heart syndrome or coarctation of the aorta. It is classically seen in association with Ebstein's anomaly, and I'll expand upon that later, as well as in patients who have heterotaxy syndrome, specifically those who have left isomerism or so-called polysplenia in association with atrioventricular canal defect. We typically see LV non-compaction in heterotaxy syndrome when the patients also have congenital complete heart block, and this carries a very, very poor prognosis. But LV non-compaction has been reported in essentially all forms of congenital heart disease. The idea that LV non-compaction can be associated with Swiss cheese septum makes sense to us because essentially the ventricular septum is non-compacted as well, and so you can see that multiple channels may develop if you have this broad non-compaction, particularly of both ventricles. And this is shown in an embryonic specimen of a mouse. And here's an echocardiogram of a patient who has Swiss cheese ventricular septum. You can see that the left ventricle apex is trabeculated, and there are multiple fenestrations in that region towards the right ventricle. You can also see that this would be very difficult for a surgeon to fix. With regard to echocardiographic criteria of LV non-compaction, there are three very classic papers which establish criteria. Essentially, the theme of the criteria are that measurements are made of the non-compacted region compared to the compacted region, and a ratio is developed to essentially tell us how much non-compaction or trabeculation the patient has. You can see, looking at these three criteria, that there might be problems with these. First of all, you don't know which one to choose. And part of the reason why you don't know which criterion to choose is because there's no gold standard for diagnosis. Also importantly, you can see from these three papers that when the measurements are made of the non-compacted and compacted region, can be at end diastole and systole or in both. And the measurement of those regions are very different in different parts of the cardiac cycle. So it's really quite difficult to know which one to choose. And I can tell you that if you have recognized patients with left ventricular non-compaction, not all of them meet the criteria that are listed above. In fact, in a recent paper, which identified a group of patients with LV non-compaction, only 79% met the Chin criteria, 64% met the Jenny criteria, and 53% met the Stolberger criteria. So you can see that if you use any of these criteria, you might miss patients who have LV non-compaction. And this is just a figure from that review paper I mentioned earlier, which shows you all the different variations of how to measure LV non-compaction. The Jenny criteria are shown in panel A. the Chin criteria in panel B, and the Stolberger criteria, which measures multiple trabeculations rather than a ratio, are shown in panel C, and the authors have come up with their own criteria in panel D. What about in children? I think it's a little bit more challenging in children how to make this diagnosis. So we've come up with the definition of a two-layer appearance of thin compact layer to thick non-compacted layer. Again, we use a ratio similar to the adult population, which is non-compacted to compacted layer of 2:1 or greater at end diastole. And this is typically assessed in the apical four-chamber or parasternal short-axis view. We try to identify prominent trabeculations in the lateral wall and LV apex, and these trabeculations move in synchrony with the myocardium. And then we can identify color flow in the intertrabecular recesses. And in most cases, we want to identify that the patient has abnormal ventricular function, but I will show you examples where a patient looks like they have LV noncompaction with normal contractility. So there are significant limitations to the echo criteria that I have just described. Patients often don't meet the criteria using all three of those methods, as I showed you in the previous slide. All of the studies have been quite small. There's no validation in a very large cohort. And importantly, there is no gold standard for comparison. So there really isn't a definitive diagnosis that we can go by. And the genetic testing has not been consistent in most cohorts that have been evaluated. Another very important issue is that many normal patients fulfill at least one echo criterion for LV noncompaction, and we may be identifying some false positives. And that can have significant clinical implications for patients. And then as the left ventricle dilates in a patient who's having a failing left ventricle, the non-compacted layer, which may appear prominent when the LV is not dilated, will appear less prominent. And so we can potentially underdiagnose those patients. This is a very elegant study that came out of Boston Children's Hospital recently. They were trying to determine the reproducibility of echo criteria in children. They identified 52 patients with isolated forms of LV noncompaction and 52 with noncompaction in association with congenital heart disease. Echoes were reviewed by two expert independent observers, and what they found, unfortunately, was that there was quite poor agreement between the observers with regard to quantification of trabeculations and that ratio that we are using to make the diagnosis of noncompaction. There was no association between the number of trabeculations or the non-compacted to compacted ratio and major events such as heart transplant and death. The thing that did associate with heart transplant and death was severe ventricular dysfunction, which is what you would expect. So left ventricular noncompaction can be overdiagnosed as well. As we've already demonstrated, the criteria are not clear-cut. And if you are identifying by echocardiography in a tangential or oblique view, you may overestimate the wall thickness, both the non-compacted and the compacted layer. And we can overdiagnose noncompaction, particularly in cases where left ventricular function appears quite normal to us. And we can also overdiagnose it when we have hypertrophy of the ventricle for other reasons, such as in patients with hypertrophic cardiomyopathy or for patients with afterload lesions, such as aortic stenosis and coarctation of the aorta. So here's an example of classic left ventricular noncompaction. You can see in the left-hand panel in an apical four-chamber view a very dilated left atrium and left ventricle with poor contractility. And I've drawn out for you the non-compacted to compacted layer seen along the side of the myocardium in the parasternal short axis view. You can see that depending on where you make your measurement, the non-compacted to compacted layer will change. And this is a patient that I think everyone would identify as having left ventricular non-compaction. You can see quite clearly the distinction between the non-compacted and the compacted layers on the left side of the panel. And you can see by color Doppler that color is going in and out of these deep intratrabecular recesses. We can even make the diagnosis of left ventricular non-compaction in the fetus. In this particular case, the trabeculations are identified in the right ventricle of this patient, but we can see it in both the left and right ventricle, and sometimes that's seen in association with dysfunction, and in other times the myocardium appears to be working normally. So here's where we get quite perplexed. This is a patient in an apical four-chamber view who appears to have prominent trabeculations down at the apex and lateral wall of the heart. You can even see by color Doppler that flow is going in and out of the trabeculations. So does this patient, in fact, have LV non-compaction? I talked about the fact that left ventricular non-compaction can be familial. And so we will typically screen families in whom one patient has been identified with left ventricular non-compaction. So here's an example of a sibling of a patient with non-compaction cardiomyopathy who is actually waiting for a heart transplant. And you can see that there are some mild trabeculations in this patient, which you can see in the apical four-chamber view and the parasternal short-axis view. But the ventricular performance is normal. So does this patient have non-compaction or not? Make a big difference to the family and the patient to make this diagnosis. And I would say that if you see a sibling who has trabeculations but has normal performance of the heart, then you need to follow that patient carefully to see if it progresses to dysfunction. In the pediatric population, we don't typically have difficulty seeing the myocardium very well, but certainly in the adult population, contrast echo can highlight trabeculations in patients who might have LV non-compaction, and that's shown by the arrows here. Three-dimensional echocardiography can also be helpful in identifying LV non-compaction. This is a paper from the group in South Carolina, which identified hypertrabeculations in patients with LV non-compaction, and they felt that they could identify them more easily by three-dimensional echocardiography in comparison to two-dimensional echocardiography. This is one of our patients who has LV non-compaction, and you can really highlight and bring out the trabeculations, hypertrabeculations in these patients with three-dimensional imaging. What about tissue Doppler? Well, tissue Doppler is used to help identify if there is diastolic dysfunction in a cohort of patients. And so this is a nice study that came out several years ago from Texas Children's, looking at a cohort of patients who had LV non-compaction compared to a normal population of children. And what they found was that essentially all indices of tissue Doppler, including EA, AA, and SA measurements, were abnormal in the LV non-compaction cohort compared to the normal children. You can see on the right side of your screen that in a patient with LV non-compaction, the EA is 4 centimeters per second, whereas in a normal patient, it is obviously much higher. And they concluded that a reduced EA velocity, in fact, less than 7.8 centimeters per second, was associated with mortality or transplant. But what you'll also note is that the group of patients with LV non-compaction had an ejection fraction of 36% compared to the normals who had an ejection fraction of 62%. So it's very difficult to know if you would be able to distinguish LV noncompaction cardiomyopathy from other forms of cardiomyopathy. In addition, tissue Doppler cannot distinguish between active contraction and passive motion, and that is a limitation of this modality. What about myocardial deformation? Myocardial deformation identifies regional shortening and lengthening of the myocardium and can be used to assess particular cardiac segments. Since we think this is a regional disease, it's probably going to be very useful to identify patients or use myocardial deformation in LV noncompaction. And it may be more sensitive than 2D and 3D echo to determine abnormal regional motion. And we can use myocardial deformation to assess strain and strain rate of the heart, as well as twist and torsion. And in LV noncompaction, it's been noted that patients who have this may have absence of normal left ventricular twist, which I will go over in just a moment. And these patients may have what's called rigid body rotation, and that's defined as when the apex and the base of the heart move in the same direction. Here's a very elegant paper done by Ben Idem, which looked at strain imaging of patients with LV noncompaction compared to normal. What you see is that you really can identify regional abnormal myocardium. Here you see on the left the patient with LV noncompaction, and you can see that the red line, the apex, is moving significantly abnormally compared to the base. Whereas on the right side of your screen, the normal patient, the strain is very similar in all the different cardiac segments. And so strain imaging may be able to help us distinguish children with just trabeculations of their heart from other reasons like hypertrophy versus children who have true LV noncompaction. I mentioned in the previous slide left ventricular twist. So it turns out that the left ventricle, in addition to contracting, actually twists like wringing out the water from a towel, such that the base of the heart twists in one direction and the apex twists in the other direction. And you can see this in the figure below, where you see that the apex and the base rotate in different directions. Peters and colleagues recently did a study of 60 adults with LV noncompaction and found that over half the patients had rigid body rotation. Again, that is defined as the apex and the base rotating in the same direction. And even the ones who did have twist had abnormalities of that twist. So the entire cohort had abnormal twist. The rigid body rotation was associated with a worse New York Heart classification, but was not associated with worse left ventricular remodeling. And this is just a really nice example of what that rigid body rotation looks like. You can see in the panel on the left in the normal heart that the apex and the base of the heart are twisting in opposite directions. Whereas on the right side of your screen, you can see that the base and the apex of the heart are twisting in the same direction, so-called rigid body rotation. Moving on to cardiac MRI of LV noncompaction, it can readily identify the trabeculations of the heart. It can also quantify the non-compacted to compacted layers. In addition to doing that, which can be done by echocardiography as well, MR can provide us delayed enhancement, which helps define myocardial fibrosis. And it can perform fractal analysis, which I'll go over in just a moment. And finally, it really has the advantage of a very accurate assessment of ejection fraction measurement. Similar to what I showed you for the echo criteria, there have been several papers which have reported the CMR criteria for non-compaction. And similar to echo, they use various measures of non-compacted to compacted wall ratios. Majority of these studies use end diastole for their measurements, and they have fairly good sensitivity and specificity. This is an example of CMR of a patient with LV noncompaction. You can see the pink arrow is measuring the non-compacted layer, and the blue is measuring the compacted layer. And you can see the multiple trabeculations, which are shown with the green arrows. Fractal analysis is an innovative way of assessing for non-compaction. Fractal dimension is a unitless measure of how completely an object fills space. So you can surmise that in a patient with LV noncompaction, myocardium will fill more space because there's more trabeculation. And indeed, this has been found. You can quantify left ventricular trabecular complexity with fractal analysis. And in this study, you can see a cohort of patients with LV noncompaction in red had significantly higher fractal dimension compared to the normal patients, which are a black and white population, in gray and blue. So it's significantly higher, fractal dimension is significantly higher in LV noncompaction patients compared to healthy volunteers, and this has very high reproducibility. We are still plagued by how to make a definitive diagnosis of left ventricular noncompaction, and Garcia-Pavia and colleagues in JACC recently came up with this criteria for adults. Fill the echo or CMR criteria with one of the following features: LV noncompaction in another family member, regional wall motion abnormality, a non-compaction related complication such as a thromboembolic event or arrhythmia, or identifying a pathogenic mutation. This is, I think, a fairly good way of making the diagnosis in adults, but it probably does not help us in children so much because many of our patients do not have a complication. So to just make things even more complicated, I wanted to present to you sort of the spectrum and presentation, if you will, and the course of disease that can occur when we are trying to consider LV noncompaction. You can have LV noncompaction be an incidental finding on an echo that's performed for other reasons such as murmur, palpitations, and such. You can have a patient who has an initially normal function with LV noncompaction who then progresses to heart failure. You can have a patient who presents with normal myocardium on echocardiography and then goes on to develop left ventricular noncompaction. You can have a patient who has what looks like LV noncompaction myocardium, which then progresses to normal appearing myocardium. And then you can have the classic presentation of heart failure with its complications. So this spectrum shows you how difficult it is to definitively make the diagnosis. I showed you this table earlier from a very early, one of the first studies, in fact, of patients with, of children with LV noncompaction. In this cohort of 36 children, of whom 5 had congenital heart disease, they were very young. They generally presented it by 3 months of age. There was 3 years of median follow-up. Of them, the majority of patients had an abnormality on their electrocardiogram, and over 80% of them had left ventricular dysfunction with a median left ventricular ejection fraction of 30%, and 9 of them who had transient recovery of their function. But you can see this is an extremely high-risk cohort. Of the 36 patients, 5 died and 4 underwent transplantation. And then this is a multi-center study that recently came out in Circulation. This is the largest cohort of patients, pediatric patients with LV noncompaction, 242, in fact, with isolated noncompaction, so not the patients who have congenital heart disease. Of those, 62 had or developed cardiac dysfunction, 13% died, of which half had sudden cardiac death, and 5% went on to cardiac transplant. Again, you can see that this is a high-risk population. The overwhelming majority had an abnormal electrocardiogram, but only a third of them had an arrhythmia, in contrast to the adult population, which are more likely to have arrhythmia. And you can see that if you have an identified patient who has LV noncompaction, that the big difference in outcome is whether they have dysfunction or not. This is a figure which shows you the cumulative survival of patients with LV noncompaction. In green, you see the patients who have dysfunction, and you can see that their mortality or their risk of death or transplant is much higher compared to the patients who do not have dysfunction. I mentioned earlier that left ventricular noncompaction might come and go, and this has been observed in patients with congenital heart disease as well as in pregnant women. This was a recent study looking at a cohort of women and following them by echocardiography through the trimesters of their pregnancy. And you can see that in this particular example, in the first trimester, this patient did not have any evidence of trabeculations, but went on to develop significant trabeculations by the third trimester, which completely resolved in the postpartum period. And so this is presumed to be related to the volume load associated with pregnancy. And Black women were 3 times more likely to develop these trabeculations than white women. With regard to congenital heart disease, we can also see changing phenotype. This is an example from the study I showed you of echo reproducibility in the pediatric population. This is an infant who had a ventricular septal defect and coarctation, which were repaired. You can see on the panel on the left that the myocardium of the left ventricle looks relatively normal. But 3 months after the cardiac repair, you can see that the ventricle has become hypertrabeculated. And the cause is unknown. And here is one of our patients who has hypoplastic left heart syndrome. So the entire ventricle you're seeing there is the right ventricle. This patient essentially does not have a left ventricle. And you can see on the initial echo after birth that there is some right ventricular hypertrophy, but the patient goes on to develop a more trabeculated right ventricle within 3 months after the initial operation. This patient also has a pericardial effusion that's unrelated, but you can see the trabeculations at the apex of the heart. And there is a well-known association of left ventricular noncompaction with Ebstein's anomaly. This is an apical 4-chamber view in which you see the atrialized right atrium and the rotational displacement of the tricuspid valve as is classic in Ebstein's anomaly. But you can see the hypertrabeculation of the left ventricle as well. And in a study out of Texas Children's looking at left ventricular noncompaction in association with Ebstein's anomaly, they determined that adverse clinical outcome was more common in those patients with noncompaction compared to those who had Ebstein's alone. There was a 30% mortality in those with noncompaction compared to 14% in those who did not have noncompaction. And of the patients with Ebstein's anomaly and noncompaction who survived, almost all developed left ventricular dysfunction. So this Ebstein's anomaly in and of itself is a relatively high-risk cohort, but left ventricular noncompaction certainly adds more risk to this population. And finally, I had described to you in the beginning of this talk that patients with heterotaxy syndrome, left atrial isomerism, may have left ventricular noncompaction. Here's an example on the left side of your screen of a patient with an atrioventricular canal defect and noncompaction of both ventricles. This is a newborn study, And so you can see that the heart rate is quite slow. This patient also has congenital complete heart block. And what you can see is 15 months later, the patient has severe dysfunction, particularly of the right ventricle, but also of the left ventricle. So left ventricular noncompaction in association with left isomerism and complete heart block carries a very poor prognosis. And this has been highlighted in a paper from Stanford. This is a path specimen of a fetus who had fetal demise, who had an AV canal defect with left ventricular noncompaction and congenital complete heart block. And you can see in this cohort of 7 fetuses, 6 out of the 7 had heart block and fetal hydrops, and all of those pregnancies were either terminated or resulted in death. The only patient who survived these findings of noncompaction with isomerism is the patient who did not have heart block. So in conclusion, left ventricular noncompaction is a poorly defined cardiomyopathy with quite variable presentation and clinical course, as you have seen from this discussion. It may present in infancy, in early childhood, or in adulthood, and we know that the presentation is typically more benign in children than it is in adults, unless the children have congenital heart disease. It likely has a genetic etiology. In some, there is a familiar pattern that has been seen, and so family members should always be screened if you have identified a patient with left ventricular noncompaction cardiomyopathy. The diagnosis now is generally made by imaging. Multimodality imaging can be useful, and serial evaluation to assess for progression and regression of disease is warranted in this population. As you've seen, there can be really quite a changing phenotype in this population. But I would advocate that genetic testing is really going to be the wave of the future in making this diagnosis. Thank you very much for your attention.